following is an MD-TV presentation. Welcome to Cardiology Today, the TV journal of cardiovascular medicine. It's estimated that more than 90% of the population afflicted with cardiac and vascular problems are cared for by their own primary care physician. To help keep you current, we shall explore the minds of the world's foremost authorities in cardiovascular medicine. We'll observe the most modern uses of their technology and report new developments from our nation's centers of cardiovascular research. So join us each month as we bring you a new dimension in physician continuing education. Cardiology Today.
Well, I was rushing to the bus, doctor, and felt that funny squeezing in my chest.
Just yesterday I had one of those attacks. Maybe I was lifting too much.
So then I lifted my grandson. Maybe that's what gave me the angina.
Naturally, patients remember the obvious attacks of effort-related angina. Further probing may reveal a history of mixed angina, effort angina plus angina during rest or sleep. At varying thresholds of exertion, upon exposure to cold. Mixed angina. It's characterized by fixed arterial lesions coexisting with vasoconstriction. Mixed angina calls for the primary protection of Procardia, nifedipine 10 milligram capsules. There have been some reports of increased angina or severe hypotension with Procardia, and when given with beta blockers, higher risk of congestive heart failure or severe hypotension. Careful monitoring of blood pressure is suggested.
Hello, I'm Bob Knowlton with the results of February's MD-TV poll question for Cardiology Today. Our question was, do you advise your patients with dilated cardiomyopathy to markedly restrict physical activity, or do you encourage physical activity? Of the physicians who responded, 65% said they would restrict physical activity. 35% said they would encourage physical activity. Please watch for this month's MD-TV poll question at the end of this program. Thank you.
This is the first program in our three-part series on cardiomyopathies. Our guests are Dr. Bill Roberts, Chief of Pathology at the National Heart, Lung, and Blood Institute in Bethesda, Clinical Professor of Pathology and Medicine at Georgetown University, and Editor-in-Chief of the prestigious American Journal of Cardiology. Our other distinguished guest is Dr. Walter Henry, Chief of Cardiology at the University of California at Irvine, and widely known as a pioneer in the clinical and research applications of echocardiography. Gentlemen, welcome to Cardiology Today.
Thank you.
Bill, I'd like to begin with how you, as a pathologist, categorize this almost endless list of causes of the group of diseases we call the cardiomyopathies.
Well, everyone, Vince, as you well know, has their own particular classification of the cardiomyopathies. I use the following, and that is the major classification is the idiopathic group, and that includes dilated cardiomyopathy and the hypertrophic cardiomyopathy. Another group of the cardiomyopathies are patients with endomyocardial disease with or without eosinophilia. Now, in America, this is not a very common condition, but in certain areas of the world, this is a major type of cardiomyopathy. A third group of cardiomyopathies are what might be referred to as the infiltrative types. These include patients with amyloid in their heart muscle, sarcoid, iron deposits, calcium, neoplasms, glycogen, any type of abnormal infiltrate into the heart muscle. It is also important to realize that the heart muscle may be affected in other types of systemic diseases like collagen diseases, infection, metabolic conditions, certain physical forces, toxins like radiation, for example. And in at least 3 neurological diseases, the heart muscle is affected. Friedreich's ataxia, for example, progressive muscular dystrophy, and myotonic dystrophy. So that in a number of conditions, heart muscle is affected.
Walter, as we're going to discover throughout our discussion today and our subsequent shows, the most useful single test in the diagnosis of the cardiomyopathy is probably the echocardiogram. How do you use the echo to categorize these patients?
Well, Vince, I think you're right that the echocardiogram has been extremely useful. And for the present discussion, we'll concentrate on the M-mode echocardiogram. In those types of studies, we pass the ultrasound beam through the left ventricle slightly below the tip of the mitral valve. And as a result, the ultrasound beam passes through the right ventricle, the ventricular septum, the left ventricular cavity, and the left ventricular free wall. In the normal echocardiogram, the right ventricle is seen as well as the ventricular septum, the left ventricular cavity, and the free wall. In the normal individual, the septum and free wall are equal in thickness and about 1 centimeter in absolute value. The internal dimension is approximately 4 to 5 centimeters and decreases about 30 to 40% during contraction. In the echocardiogram of a patient with a dilated cardiomyopathy, we see a marked ventricular dilatation, a very poor motion of the ventricular septum and free wall, and a substantial reduction in the percentage change in the diameter of the left ventricle, typically around 10 to 15% in extreme cases. In the patients with hypertrophic cardiomyopathy, the ventricle is normal in dimension and systolic function, but the ventricular septum is enormously thick, and that seems to be the characteristic feature of this condition. Finally, in the infiltrative cardiomyopathies, the ventricle is typically not dilated, has normal systolic function, but both the septum and free wall are thickened due to the infiltrative process, and usually to about the same degree.
Thank you, Walt. I'd like to spend the remainder of this program talking about the dilated form of cardiomyopathy. Bill, from the standpoint of the pathologist, what is a dilated cardiomyopathy?
As Walter indicated, Vince, the dilated group of cardiomyopathies are characterized by dilatation of both the ventricles. That dilatation affects always both, not just the right or the left. The second feature which characterizes the dilated group is that the muscle mass is increased. At necropsy, for example, the weight of the heart is always above normal. The other features really are negative ones. That is, the coronary arteries are not significantly narrowed, although virtually all of these patients at some time or another, as you know, have precordial murmurs. The valves themselves are normal. The surface of the heart, the epicardium, is normal. There are no infiltrations by granulomas or sarcoid or whatever into the heart muscle itself. Indeed, inflammatory cells, at least at the time of necropsy, are not present. I should mention also that the atria are a little dilated, but they are not dilated nearly to the extent, as we will discuss later, as in patients with hypertrophic cardiomyopathy or indeed amyloid. So the key feature of dilated cardiomyopathy is dilatation of both ventricles, and that dilatation is not the result of valvular heart disease or coronary heart disease.
Thank you, Bill. We'll be back in 1 minute.
Millions of people worldwide are affected by osteoarthritis, a disease with no known cure. There is, however, a non-steroidal anti-inflammatory analgesic available in over 60 countries. Indicated for the pain and inflammation of osteoarthritis, naproxen from Syntex is backed by over a decade of clinical experience. For the patient experiencing the symptoms of osteoarthritis, painful tender joints, stiffness, and decreased mobility, a good treatment plan can help. Rest, exercise, and naproxen 375 milligrams twice a day should provide symptomatic improvement of osteoarthritis within 2 weeks. Naproxen, for reduction in pain, stiffness, and joint tenderness, backed by a world of experience. Naproxen, for the pain of osteoarthritis. Naproxen is contraindicated in patients who are hypersensitive to it. The most frequently reported adverse reactions relate to the gastrointestinal tract. See end of program for brief summary of prescribing information.
We are discussing the dilated cardiomyopathies. Walter, let's continue our discussion with just how patients with dilated cardiomyopathies present to us clinically.
Well, Vince, patients with dilated cardiomyopathies frequently have symptoms of left heart failure, including dyspnea on exertion, fatigue, and weakness, and when extreme may have PND and orthopnea. In addition, a typical presentation may be following an alcoholic binge when patients present an atrial fibrillation, and this is not an uncommon way to see patients. More frequently, we're seeing patients who have been asymptomatic and who are picked up either by an echocardiogram or on a routine chest x-ray with evidence of a dilated cardiomyopathy. In terms of the history, it's important also to question the patient carefully, not only about alcohol consumption, but also about toxic exposure and infectious agents as well.
Bill, let's interrupt a second here. We mentioned alcohol. How does alcohol cause a cardiomyopathy?
Well, Vince, as you know, that's been debated for years. There is one school of thought that virtually all patients with dilated cardiomyopathy are habitual alcoholics. And that appears to be true in men particularly. A very high percentage of the men with dilated cardiomyopathy are indeed alcoholics, apparently. Women, that's not the case. In the studies that done in my lab, the patients that we've studied at necropsy, relatively few of the women were alcoholics. When we look at the hearts of the alcoholics versus those who were not known to be habitual alcoholics, there are absolutely no differences morphologically. So I think that really one has a hard time in proving alcohol as an etiologic factor here. For example, patients with cirrhosis of the liver due to alcoholism virtually never get dilated cardiomyopathy.
If a woman patient who has a dilated cardiomyopathy denies alcohol intake, she's probably telling the truth, correct?
I would think that's the case.
Walter, we have a patient who we now suspect has a dilated cardiomyopathy. How do we go about proving or disproving this diagnosis?
Well, several of the things we've relied on in the past events have been relatively non-specific, including the physical examination, which may show evidence of displacement of the cardiac impulse, atrial gallops, occasionally third heart sound gallops as well. The chest x-ray may show varying degrees of cardiomegaly and pulmonary venous congestion, again, relatively non-specific finding. The electrocardiogram may show low QRS voltages, frequently show atrial and ventricular ectopy, but again, non-specific findings frequently. It's in this context that the echocardiogram has been very useful. In the normal individual, a two-dimensional echocardiogram will allow us to see the right ventricle, the ventricular septum, the left ventricular cavity, and the left ventricular free wall, as well as the aorta, the left atrium, and the mitral valve. In a normal two-dimensional echocardiogram, there is a very good motion of the ventricular septum and free wall. The ventricular cavity is not dilated, and neither is the aortic root or the left atrium. In the patient with a dilated cardiomyopathy, both the ventricular septum and left ventricular free wall appear thin. However, in terms of absolute values, they're normal in thickness. They appear thin because the left ventricle is very dilated. As you can see from a two-dimensional echocardiogram, the septum shows very poor motion, so does the left ventricular free wall. The mitral valve opens very poorly because of the low stroke volume. And indeed, when you look at the overall function of these hearts, sometimes it's difficult to even tell whether or not the ventricle is contracting at all in some of these people with extreme forms of the disease. In terms of other findings, the catheterization data will reveal elevation of left ventricular end diastolic pressure. Usually pulmonary capillary wedge pressure is increased as well. In terms of angiographic findings, we see what we would appreciate from the echocardiogram, a dilated left ventricle with a very low ejection fraction. Occasionally we see mitral regurgitation as well in these individuals, but usually of a relatively mild degree. I would say, however, that if an echocardiographic study is obtained and is of good quality, with the exception of ruling out coronary disease, we usually can find out the information we need to know from an echocardiographic study, and not very frequently do we have to take these patients to the cath lab and do an invasive study.
What role does endomyocardial biopsy play in evaluating or even treating these patients?
Well, I think there's some controversy about that right now. There have been some studies suggesting that if you biopsy these individuals, you may find evidence of an inflammatory process, and that those patients will respond to a steroid therapy, for example. Perhaps Dr. Roberts would want to comment.
Dr. Victor Ferrands in my lab has looked at probably 200 biopsies now in patients with cardiomyopathy, most of whom had dilated cardiomyopathy, and inflammatory cells are extremely rare. That's been an assumption that clinicians have lived on for years, that myocarditis might be the initial manifestation, or at least morphologic manifestation of this entity. But as far as I'm concerned, inflammatory cells are absent or extremely rare. I think the biopsy for the patient is not very helpful.
Thank you, Bill. We'll be back in 1 minute.
We're that neighbor who's always ready to lend a helping hand. We help when disaster strikes, during fires, floods, hurricanes, and tornadoes. We help with food, clothing, health care, and a place to stay. We help when folks need blood. We help the elderly. We help expectant parents prepare for their baby. We help veterans get their benefits. We'll teach you how to check blood pressure. We'll teach you CPR, swimming, and first aid. We'll help you learn how to take better care of yourself and your family. We're the American Red Cross, people helping people. Everyone working together to improve things in your community. That's what Red Cross exists for. Join Red Cross. We'll help. Will you?
We're continuing our discussion of the dilated cardiomyopathies. Bill, what is the natural history of the patient who has a dilated cardiomyopathy?
Vince, my colleagues and I have studied 154 patients with fatal dilated cardiomyopathy, and as this graph shows, the half-life from the onset of congestive heart failure, known in 118 of those patients, was between 24 and 36 months. Of the entire group, the average length of illness from onset of manifestations of congestive heart failure was 48 months. Now, of course, all of the patients that I've studied have died. There are some who live. It's very difficult sometimes to predict early on, as I understand it, which ones are going to have a reversal of their illness and which ones are going to have a progressive downhill course. But this is a bad condition.
Certainly, though, you agree that not every patient who has a dilated cardiomyopathy is going to necessarily need a heart transplant.
Well, that's one form of therapy for those patients who do progress to class 4, but certainly that should be reserved only for the desperately ill patient.
When we consider natural history, we have to take into account whether the patient is continuing drinking or not, because alcohol is a major factor. Do we have any evidence that if a patient with a dilated cardiomyopathy does stop drinking alcohol, does the disease stabilize or even does it improve?
Well, I think all physicians, of course, recommend the discontinuation of alcohol consumption once this diagnosis is made. As far as I know, there are not good studies showing that the discontinuing of drinking alcohol, however, has a great deal of effect on the course. So I think it should be discontinued, but whether it's going to really be useful it remains to be seen.
Walter, it looks like a pretty dismal disease so far. Is there anything we can do to treat these patients to help them?
Well, certainly, Vince, there are a lot of things we can do that can be quite useful in treating these patients. The first thing I think is important is to consider the etiology. And if in fact alcohol is the cause of the dilated cardiomyopathy, which it is in a great majority of patients that we typically see, then we should make a vigorous effort to talk the patient into stopping a heavy consumption of alcohol. Having said that, that's usually quite difficult to do. I believe if you can get to individuals early in the course of the disease before the cardiomyopathy is severe, that stopping drinking can in fact have a positive impact on the natural history of patients with alcoholic cardiomyopathy. Those people with mild abnormalities by echo may very well be able to be treated simply by watching the salt intake in their diet and by discontinuing alcohol. In people with a more well-established disease process, digitalis and diuretics are the mainstay of therapy in these patients, and frequently can stabilize the symptoms for some significant period of time. In those patients in whom the cardiomyopathy is very well established and not responding well to digitalis and diuretics, treatment with afterload reduction therapy can be quite helpful. In our experience, we frequently follow these patients using Doppler echocardiography to measure relative changes in stroke volume. And as we can see from this graphic, in the individual who has a dilated cardiomyopathy prior to afterload reduction therapy, we have a certain area under the flow curve indicating the relative stroke volume. Following vasodilator therapy, the area under this flow curve has increased substantially, showing that the major benefit of using afterload reduction therapy is to increase forward stroke volume, which can be quite helpful in these patients. I would point out that in terms of prognostic findings, the presence of ventricular tachycardia in patients with very low ejection fraction is an ominous prognostic sign. In fact, the yearly mortality in that subgroup of patients is between 30 and 40%. My recommendation would be that those patients have that ventricular arrhythmia very vigorously treated, perhaps even by someone with special expertise in the treatment of malignant arrhythmias. In that context, beta-blocking drugs may have some benefit, although I would emphasize that beta blockers in this particular type of cardiomyopathy are controversial and should not be widely used until further work is obtained.
What about anticoagulation?
Anticoagulation is quite important in these people. They frequently have evidence both pathologically and by ultrasound of clots in the left ventricle, particularly when the ventricle is very dilated, and anticoagulation therefore would be beneficial. Unfortunately, many of the alcoholic patients we see are not very good citizens, and because of that, anticoagulation has to be used in only a selected subset of people.
Thank you, Walter. Thank you, Bill. I'll return in 1 minute with our summary.
Hello, I'm Bob Knowlton with the March MD TV poll question for Cardiology Today. Hypertrophic cardiomyopathy has been found to be one of the most common causes of sudden death in young athletes. Do you believe that every young athlete with a heart murmur should have an echocardiogram to rule out this diagnosis? If your answer is yes, dial 900-200-3720. If your answer is no, dial 900-200-3727. These are toll-free numbers. Results will be announced in next month's Cardiology Today. Results are also available in your monthly issue of the MD TV program guide. Please let us hear from you. Thank you.
Charles, what would you recommend?
May I suggest something delicious, light, and low in cholesterol? Do you realize the lower the cholesterol in your body, the lower your chance of heart disease?
No, I didn't know that.
Would I lie?
Well, I'm for less heart disease.
Well, so am I.
Does my heart good.
Delicious, Charles. Thanks for the tip.
Well, if there's one thing I know, it's a good tip.
The American Heart Association. We're fighting for your life.
The editors of the MD TV program guide welcome viewers' letters on any segment presented on the MD TV network. This is your forum to ask the hosts and guests appearing on the network questions, as well as to voice your comments, suggestions, and criticisms of MD TV programming or of the program guide. Letters should be addressed to Editor, MD TV Program Guide, in care of Transmedica, 801 2nd Avenue, New York, New York, 10017.
Let's take a minute to summarize our discussion on the dilated cardiomyopathies. The pathological features are highlighted by dilation of both ventricles and an increase in the myocardial muscle mass. Although the exact cause is uncertain, excessive alcohol intake is common in men, but rare in women with this condition. Patients usually present with symptoms of left heart failure, but many are asymptomatic. Echocardiography is the best means for diagnosis. Therapy includes discontinuing alcohol and giving diuretics, digitalis, afterload reduction, and anticoagulation. This concludes our first program on the cardiomyopathies. Please join us on our next program when we will discuss hypertrophic cardiomyopathy. Until then, thank you for joining us.